Hi, my name is Daryl Tauro. This is my presentation on cortical implants, specifically on their applications to restoring vision. So what are cortical implants? Cortical implants are implants that interface directly with the cerebral cortex. Typically, multi-electrode arrays are implanted. The goal of cortical implants are to replace neural circuitry in the brain that no longer functions appropriately. As you can see on the right, the multi-electrode array would be implanted to that part of cerebral cortex which needs to be treated. So for example, in the case of a blind person, the visual implant would be implanted within the visual cortex in order to provide treatment. Hence, in that way, it can be used to build visual implants, auditory implants, or cognitive implants. Restoration of vision. Blindness results from an interruption in the normal flow of signals along the vision pathway. As you can see in the figure on the right, that could be due to damage or disease to the retina, the optic nerve, or the lateral geniculate nucleus. For functional vision, a prosthesis would have to excite neurons at some point downstream of this damage site. Since blindness is usually of retinal origin, the visual cortex is the preferred site of stimulation. It is not just due to this, it is multiple factors that make it so. It is also mainly because most damaged neurons, the visual cortex, it tends to be outside of the pathway of most damaged neurons, and hence this makes it suitable for cases of late blindness, especially the retinal or optic nerve disease or injury. It is also that the large surface area of the visual cortex makes it ideal for implanting electrodes, and it makes it a lot easier to implant electrodes as compared to the retina or the LGN. Visual cortical implants. Visual implants are electrodes implanted directly into the visual cortex. Such a system, as shown in the figure on the right, would consist of a video camera placed near the eye or mounted on the head, which would capture images, process them, and manage electrical stimulation. It would transmit information and data either wired or wirelessly to the implant, which would be within the visual cortex, and this implant would generate the electrical stimuli necessary while monitoring the electrode tissue interface to ensure that everything is in order and there's no damage to the neural tissue. So in order for a cortical visual prosthesis or a CVP to be viable, and a device to test chronic stimulation of neural tissue needed to be developed and studied. And this was done in 1968 by Dr. Brindley and Dr. Lewin. They developed their own version of a human prosthetic implant, which they tested on a 52-year-old patient. They were successful and found the stimulation of an electrode placed at the right occipital pole caused the blind patient to experience spots of light, or what they call phosphenes. Since they wanted to create a vision process with minimal invasive surgery, they used coils which pulsed radio wave signals through the scalp, and these coils were tuned to an appropriate frequency and placed above the electrode they were interacting with. They found that similarly multiple electrodes created multiple phosphenes as long as electrodes were placed 2 to 4 millimeters apart. Phosphenes are found to remain and only ceased on ceasing the stimulation. They are also found to move with voluntary eye movements. That is, if the person moved left side, the phosphenes will move along with the person, but they were fixed for movement of the head, that is vestibular movement. The prototype human prosthetic implant. This implant consisted of 80 radio receivers encapsulated in rubber, and the receiver was joined by a cable to the intracranial part fit on the calcarine. As can be seen in this figure, the transmitting coils are what can be seen on the right and the left and top of the skull, and the cable can be seen joining them to the 80 platinum electrodes within. The receiver is of course activated by the coil of the oscillator, and radio signals are pulsed. So they found most patients describe the phosphenes as white small spots of light, much like distant stars in the sky. Phosphenes are found to be distinguishable as long as electrodes are placed far apart. When they were placed close by, the phosphenes are found to diffuse and form a long strip. They have found that patterns could be built by synchronous stimulation of electrodes, and they found the sensations produced by stimulation were always of light, never of darkness. Non-visual sensations reported included minor tingling in the scalp. However, deep pain was reported, and this was hypothesized to be due to the interaction with the meningeal pain fibers and was a major cause for concern. No flicker fusion frequency was recorded, and this refers to the frequency at which the phosphene is said to flicker, and there was no correlating data in order to find a particular frequency. However, ultimately Dr. Brindley and Dr. Lewin strongly suggested that a useful process was possible by improving upon their prototype, and this was done by Dr. Dobell and Dr. Lewandowski in 1974. They tested the various stimulation parameters by studying the electrode interactions with neural tissue in a group of 38 volunteers. They did not develop an entire visual prosthesis. However, but most of their findings matched that of Dr. Brindley and Dr. Lewin. However, they had some findings that directly conflicted those of Dr. Lewin. They found that phosphenes were produced from stimulation of the primary visual cortex, as usual, and they found that they require threshold currents of about 5 milliamperes in order to produce the phosphenes. As can be seen in the figure on the right, in the upper part of the figure shows the use of um, different electrode sizes in order to study the effect electrode sizes would have on the phosphine. It was found that they had minimal or no effect at all, and it was found that smaller electrodes are preferred in order to improve spatial resolution, as can be seen in the figure on the bottom right. Dobell hypothesized, Dr. Dobell hypothesized that the placement of the phosphine in the visual field would correlate in some way to the placement of the electrodes, and it was found that the placement of the phosphine in the visual field did correspond roughly to a classical map of the visual cortex to the placement of electrodes within a classical map of the visual cortex in some way. However, there were some conjugate phosphines, which I'll talk about later, that were found that did not match this map. As you can see in the left part of the figure shows the electrodes implanted within and the wires extending to the skull. Effects of the phosphine produced. Most phosphines are found suitable for use in the visual prosthesis. However, in certain cases, multiple phosphines could be produced by stimulation of a single phosphine. These could manifest either as a cloud of phosphines or in certain cases as a conjugate phosphine. Conjugate phosphine implied that in this case, when the electrode was stimulated, at a low threshold there would be a certain phosphine produced, and then at a higher threshold there would be a phosphine produced in the opposite part of the visual field. There were also chromatic effects noticed by the patients, especially vivid colors like red, blue, or green. There was no flicker in the phosphines, or rather the flicker in the phosphines could not be explained or correlated. However, the major finding that they had, which conflicted with that of Dr. Brindley and Dr. Lewin, was that they found that phosphines faded within 10 to 15 seconds even after continuous stimulation, whereas Dr. Brindley and Dr. Lewin found that the phosphines did not fade while applying continuous stimulation. Hence, these differences in findings are explained by the differences in the conditions resulting in blindness in the patient in both the studies, and also the different methods used. In one case of an actual visual prosthesis, in, an actual in case of Dr. Brindley and Dr. Lewin, the prosthesis was affecting a different part of the visual cortex as opposed to Dr. Dobell. Then in the 1990s, a group at the National Institute of Health, headed by Dr. E.M. Smith, published a paper on the various describing the parameters for intracortical microstimulation. They were motivated to do so by reports of low stimulation thresholds by using this method for stimulating the visual cortex in primates. They found that more precise control of the neuronal function was possible by implanting microelectrodes. This is because the exposed tip size is approximately the same size of the neuron as can be seen in the figure on the right, with the iridium electrodes having exposed tip size the order of size of the neuron, that is 20 micrometers. They also found that they had a much lower stimulation threshold of about 25 microamps compared to 5 milliamps as recorded by Dr. Dobell. They also found that phosphines are produced by 34 of the 38 microelectrodes, and they found the electrodes placed 0.5 millimeters apart generated separate phosphines, which is almost a 5 times improvement in spatial resolution. As you can see on the figure on the left, the photograph of the exposed surface of the right visual cortex, with the dots indicating the points at which the electrodes would be implanted. The figure on the left shows the threshold currents recorded for the microelectrodes, and as you can see, most of them are well below 25 microamps. The results of intracortical microstimulation basically stated that the phosphene brightness varied with stimulus amplitude, frequency, and pulse duration. They found phosphene sizes to vary from pinpoint to a nickel. They, however, reported that all phosphenes were located in the left hemifield and most clustered within a small area, matching findings by that of Dr. Brainley as well as Dr. Dovell that most of the phosphenes would be clustered within a small area on stimulation with multiple electrodes, and this area was roughly about 10 degrees of the field of vision. But their major finding was that their greater microelectrode density allowed them much greater neuronal stimulation, that too with lower power and less danger to the surrounding neuronal tissue due to the smaller size of the electrode. However, cortical visual implants are still in the early stages of research, and hence we must turn our attention to retinal implants. It is also that more study needs to be done into cortical implants, especially the safety concerns of intracortical microstimulation and further research into precise eye tracking and accurate methods of mapping phosphenes. Retinal implants, however, can also benefit a large proportion of the population, especially those suffering from retinal diseases like retinal pigmentosa and age macular degeneration, as shown in the figures on the top right and on the right top and the right middle. Retinal pigmentosa is a degenerative disease that affects anyone from infancy to late adulthood, which affects the rod photoreceptor cells in the retina. Age macular degeneration only affects those in early to late adulthood, and it results in a loss of the visual field due to damage to the retina. Both of them have shown promise. Both of them have shown good results when being treated with a retinal implant. Retinal implants can be either epiretinal, that means they will be implanted on the inner surface of the retina, or subretinal, where they will be implanted on the outer surface of the retina, as can be shown in the figure on the bottom right. The cells between the epiretinal and the subretinal implant indicate all the cells that implement the natural visual processing from which the retinal implant benefits, and hence it requires less advanced vision processing strategies as compared to that of a cortical implant. The implant could also be a microphotodiode array or a microelectrode. Future prospects include improvement of spatial resolution by increasing the number of electrodes, as can be shown in the top right figure, which is the Utah microelectrode array consisting of up to 96 electrodes, and is one of the go-to devices in order to do research in this field of neuronal stimulation. However, with increased electrodes, you have increased safety concerns, greater crosstalk, and larger power consumption, which all need to be addressed. There is also a mobility constraint in which most of the phosphenes are produced within a very narrow field of view, approximately 10 degrees. There would be a need to see if this could be extended in some way. There would also be a need for head movement scanning due to the mounted camera, as since phosphenes remain fixed, there is no way to tell what direction the person is facing. There needs to be a lot of studies done into the long-term safety and efficacy of intracortical microstimulation, as well as the long-term durability for such an implant, as it would need to be minimally invasive and would require a person to have to go for checkups very rarely. Finally, there needs to be a good development of pre and post-operative programs, as well as good patient screening in order to ensure proper research is done, so that one day very soon we might have visual prostheses available in order to benefit whoever may need it. Thank you.